what if the reason you hated your last therapist had absolutely nothing to do with the therapy itself?
Right.
And, it had literally everything to do with how you found them in the first place. I mean, think about it. You finally make this really daunting decision to ask for help. You open your laptop, and you are immediately confronted
Like
with,
the directory.
yes,
Ah.
the endless scrolling directory of smiling headshots. Just pages and pages of them.
It's a completely paralyzing experience. You are already in a state of vulnerability, you're seeking support, and suddenly you're expected to act as like a human resources director.
Exactly.
You have to vet these complex clinical candidates based on a 2-sentence bio, a really vague list of specialties, and I don't know whether or not they're wearing a reassuring cardigan in their photo.
Which is wild. And most
Yeah.
of the time, you just end up swiping through this directory, closing your eyes, and hoping that someone, like anyone, will be the right fit for what you're going through.
You're just guessing.
Right, you're just guessing. So today, we are looking at the fatal flaw of the therapist directory. We're diving into a stack of notes and excerpts from a fascinating source called The Architecture of Therapeutic Alignment.
Hmm.
And specifically, this material focuses on coping and healing counseling, or CHC. They're a telehealth therapy practice based out of Georgia.
And we should clarify, we are using their model not as like a simple review of a clinic.
Right, this isn't a Yelp review.
No, not at all. We are looking at it as a structural blueprint. We are examining the actual mechanics of how a healthcare practice engineers a successful match between a client and a clinician. Basically, how they remove that awful directory entirely.
The mission for this deep dive is to look at exactly how you find a therapist who actually fits. Okay, let's unpack this. Because before we can really look at how to match a client and a therapist, we have to talk about why the traditional guess and check method is so deeply flawed from a psychological standpoint.
Yeah, the directory method fails primarily because it ignores the most foundational element of successful therapy.
Which is,
Well, when we review the clinical data, the research consistently points to one core fact. The therapeutic relationship itself is one of the strongest predictors of positive clinical outcomes.
wait, let me make sure I'm hearing you correctly.
Yeah.
You're saying the actual relationship between the two people on the screen
Yes.
is a stronger predictor of success than, I don't know, the specific coping worksheets they hand you or the homework you do between sessions.
What's fascinating here is the neurobiology behind that very concept.
Oh, wow.
Yeah, those cognitive tools and worksheets are highly important, obviously, but the container in which those tools are delivered is the relationship. If there is no trust, no alignment, and no fundamental feeling of safety between the client and the therapist, the client's brain remains in this subtle state of defense.
Like a fight or flight thing.
Exactly. The amygdala is on guard. And in that state, you literally cannot effectively engage the prefrontal cortex to, process trauma or learn new behavioral patterns.
So you're just blocked.
Completely blocked. The best worksheets in the world cannot bypass a lack of relational safety. The alliance dictates the success of the treatment.
But that highlights a massive contradiction in how the mental health system usually operates.
Oh, absolutely.
If a relationship is the single most critical factor for healing, why are most clients left entirely to guess who they will click with? I mean, think about it this way. Is picking a therapist from a massive list without any guidance, basically like trying to pick a reliable mechanic by putting a blindfold on and throwing a dart at a phone book?
That is a highly accurate analogy, actually.
Right. Because you wouldn't trust your car's transmission to a random dart throw. You'd ask what kind of cars they work on, if they understand your specific engine. So why on earth do we accept this blind dart method for our own mental health, which is, infinitely more complex than a car engine?
The systemic gap there is profound. I mean, we have clinical research shouting that a strong therapeutic alliance is vital, yet the average person receives zero structural guidance when trying to find care. And when a system leaves a client to guess, it essentially gambles with their mental health outcomes. If they guess wrong, they have a miserable first session, they feel unheard or misunderstood, and the tragic result is that they often just walk away from therapy altogether.
Yeah, they just ghost.
Right. They internalize the mismatch and think, well, therapy just doesn't work for me.
Which is heartbreaking because the therapy didn't fail. The match failed.
Exactly.
The dart just hit the wrong target. So if guessing is statistically destined to fail for so many people, how should a practice engineer a successful match? How do we basically take the dartboard out of the equation.
You have to replace that passive directory scrolling with an active, intentional intake architecture. And looking at the source material regarding CHC's model, they completely remove the directory from the client's hands and replace it with a structured assessment.
Right. I'm looking at the notes on how they do this, and I have to push back a little bit here.
Okay, go ahead.
Because according to the source, as a new client at CHC, you fill out a quick intake form indicating your specific needs. Things like anxiety, grief, ADHD, trauma, or relationship issues. But hold on, how much can an intake team really glean from a web form? If I just check a box that says anxiety, I mean, that is incredibly broad.
It is.
So how does an intake coordinator translate a basic checkbox into actual human chemistry and a true clinical match?
Well, that is where the architecture moves from administrative to clinical. The intake team isn't just looking at the word anxiety and finding the next open time slot.
Okay.
They are translating your specific presentation of anxiety into a specialized clinical license and modality. For instance, CHC has over 15 licensed Georgia clinicians, but they hold different types of licenses: LCSWs, LPCs, and LMFTs.
Okay, I've seen those letters after therapist names for years, but I'll admit I have absolutely no idea what the functional difference is.
Most people don't.
Why would a client need one over the other?
It alters the lens through which your treatment is viewed. So an LCSW is a licensed clinical social worker. They are highly trained to look at the individual within their broader systems.
Like their environment.
Exactly. Environment, systemic pressures, resources. Now, an LPC is a licensed professional counselor who might focus much more deeply on the internal individual psychological process and cognitive framing.
Got it. And the last one.
An LMFT is a licensed marriage and family therapist. They specialize in the dynamics of relationships, viewing the family unit or the couple as an interconnected system. So the intake team's job is to look at your form and decide which of those lenses is best suited for your specific struggle.
Here's where it gets really interesting, because the matching goes even deeper than just the license type. I'm looking at the source material, and there's a whole alphabet soup of acronyms regarding the modalities these clinicians use. But I think there's a huge pop culture stereotype we need to challenge first.
Oh, I know where you're going with this.
Right, because when a lot of people picture therapy, they picture an older gentleman sitting in a leather chair, puffing on a pipe, just listening and nodding and occasionally asking, and how does that make you feel?
The passive observer model. It is a persistent and very outdated Hollywood version of what happens in a clinical setting.
Exactly. But the notes highlight that CHC's team is trained in specific evidence-based modalities that are far from passive. The problem is, I don't know what half of these mean.
We can walk through them.
Let's do that. For trauma, they mention EMDR and CPT. For anxiety and OCD, they utilize CBT and ERP. For perinatal mental health, they have PSI-trained clinicians. Can we break down the actual mechanics of these? Like, what do these acronyms actually mean in a practical sense?
Let's start with trauma and EMDR, which stands for eye movement desensitization and reprocessing.
Okay.
When someone experiences severe trauma, the memory often gets basically stuck in the brain's emotional center, triggering really intense physiological reactions long after the event.
Like a flashback.
Right. And passive nodding won't fix that. EMDR is a highly structured framework where the clinician uses bilateral stimulation, like guided eye movements from side to side. And they do this while the client focuses on the traumatic memory. This overloads the brain's working memory, which actually allows the brain to fundamentally reprocess how the trauma is stored.
Wow.
Yeah, it strips away the intense emotional charge.
So it's an actual neurobiological intervention, not just venting about your week.
Exactly.
Okay, what about ERP for anxiety and OCD? Are they actively exposing the client to their fears on a video call?
Yes, but in a highly controlled manner. ERP stands for exposure and response prevention. It is the gold standard for obsessive-compulsive disorder.
How does it work?
The mechanism here involves the clinician deliberately guiding the client to confront the thoughts, images, or situations that trigger their anxiety.
That's the exposure part.
Right, and then actively preventing them from engaging in their compulsive behavior, which is the response prevention.
That sounds really intense.
It is, which is why it requires a clinician who knows exactly how to pace those exercises. A generalist who hasn't been trained in ERP might just try to talk a client out of their OCD, which can actually reinforce the anxiety loop.
Makes total sense. And the PSI training for perinatal mental health.
PSI refers to Postpartum Support International. Clinicians with this training deeply understand the profound, complex interplay of hormonal shifts, identity loss, and psychological distress that happens during pregnancy and postpartum.
That's a very specific experience.
It is a highly specialized biological and psychological context that a generalist might entirely misinterpret.
The source also notes they serve teens, anyone 13 and older, couples, families, and they even offer life coaching. Plus, the team is explicitly described as diverse and culturally competent.
Which is huge.
Yet, mechanically speaking, it makes total sense. Your cultural background fundamentally shapes how you experience the world, how you express emotion, and how you process distress. If your therapist doesn't understand your cultural context, that baseline of safety we talked about earlier is going to have a massive crack in its foundation from day one.
If we connect this to the bigger picture, the direct result of this matching architecture is profound. When you pair a client with a clinician who possesses the exact right license, the precise evidence-based training for their condition, and a shared or deeply understood cultural lens,
What happens?
you see a significant reduction in client drop-off rates.
Because they actually feel understood on a structural level right out of the gate. They aren't spending the first 6 sessions just trying to translate their existence to a total stranger.
Exactly. It protects the continuity of their mental health care. When the guesswork is removed from the front end, the clinical work like the EMDR, the ERP, the cognitive restructuring can begin almost immediately.
Okay, so we have a system that uses evidence-based matching to get you in the right room. But a clinical match on paper doesn't guarantee human chemistry.
No, it doesn't.
What happens when the algorithm does its job perfectly? The specialty aligns, the cultural background aligns, the scheduling aligns, but then you, as the client, log onto the video call, you start talking, and you immediately realize, okay, I just do not like this person's vibe.
Right, the chemistry is just off.
Yeah. What happens when the perfect formula fails in practice?
Well, it is an unavoidable reality of human interaction. Two people can look completely compatible on paper and simply lack rapport. A robust clinical model cannot pretend this doesn't happen.
Right.
It has to account for that failure rate structurally.
And according to the source material, CHC accounts for this with a very active, explicit policy. Switching therapists is not only allowed, it is openly encouraged if the fit isn't right. They utilize a 3 to 4 session rule. The guidance is that if it doesn't click by the 3rd or 4th session, you can ask to be rematched with another clinician at no extra charge.
Which is brilliant because 3 to 4 sessions is a highly strategic clinical timeline. The first session is usually intake and history gathering. The second and third are where you begin to establish a rhythm.
Just getting to know each other.
Right. By the end of session 4, you have a very clear, intuitive sense of whether you feel psychologically safe with this person.
But this policy brings up a massive behavioral hurdle. Isn't the sheer awkwardness of essentially breaking up with your therapist one of the biggest reasons people stay trapped in bad therapy or just, ghost the clinic entirely?
Oh, without a doubt.
Because it requires a client to say to a professional, I don't think I like working with you.
This raises an important question about the power dynamics inherent in therapy. We have to acknowledge that for many clients, the therapist is viewed as an authority figure.
Right, they're the doctor.
They are the expert in the room. To tell an authority figure that their approach isn't working requires a level of self-advocacy and assertiveness that a client who is already struggling with their mental health, mind you, might simply not possess at that moment.
Especially if they struggle with people-pleasing, or if they came to therapy specifically to treat severe social anxiety.
Exactly.
The thought of offending the therapist might trigger more anxiety than the condition they are trying to heal in the first place.
Which is why officially giving clients permission to switch and making it a stated, transparent policy from the very beginning is a brilliant structural intervention. It completely destigmatizes the mismatch.
It takes the pressure off.
It removes the burden of guilt and the fear of confrontation entirely from the client's shoulders.
Because it shifts the narrative. It's no longer a personal rejection of the therapist. It's just a client following established clinic policy. You're just pulling the lever they told you to pull if the engine didn't start.
Yes. Framing a mismatch not as a personal failure, but as a deliberate, anticipated part of clinical practice, actively protects the client's ongoing engagement. The implicit message is, we expect this to happen sometimes. When it does, it means our system is catching the error, not that you are failing at therapy.
Wow.
It keeps them engaged with the healing process instead of just running away out of social awkwardness.
That is a profound shift in empowering the client to be an active consumer of their own healthcare.
Yeah.
But, having the perfect scientifically designed match and having this wonderful psychological safety net that allows you to switch without guilt,
Right.
all of those incredible clinical benefits are completely useless if you literally cannot get in the door.
Mm-hmm.
Or, in this case, if the systemic barriers to specialized mental health access keep you entirely shut out.
Absolutely.
Let's talk about the logistics of access here, because the notes on CHC highlight a very systemic approach to overcoming these barriers.
Access and logistics are often the most formidable gatekeepers to mental health care. You can design the most elegant therapeutic architecture in the world, but if the bridge to access it is broken, the architecture serves no one.
First off, the source notes that this practice is 100% telehealth and fully HIPAA compliant. And because they are telehealth, they cover all 159 counties in the state of Georgia. Why is that specific geographical detail so critical?
Because it addresses a massive systemic failure regarding geographical equity in healthcare. In many rural counties across the country, specialized mental health care is functionally non-existent.
Just not there at all.
Not there. If you live in a rural area and suffer from severe OCD, finding a clinician actively trained in ERP might require a 2 or 3 hour drive each way.
Which is just not sustainable.
It's impossible. That geographic barrier effectively means you simply do not get treatment. Telehealth instantly collapses that distance. It provides the exact same roster of specialists to a resident in a remote town as it does to someone living in downtown Atlanta.
But geography is really only half of the systemic barrier. The other half is obviously the financial reality of the mental health industry. Let's look beyond just reading off a list of insurance providers, because the financial model outlined in our source material is striking.
It is. The barrier of cost is often the definitive reason individuals abandon their search for specialized care entirely.
Yeah.
The traditional model often places the financial burden squarely on the patient through massive out-of-pocket fees.
Yes. When you look at specialists, especially those trained in modalities like EMDR or ERP in major metropolitan areas, you are often looking at out-of-pocket costs ranging from $150 to over $200 for a single hour.
Per session. It's staggering.
But the notes show that CHC accepts Medicaid, which carries a $0 copay. And for their commercial insurance options, which include Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana, the copays range from $10 to $40 per session.
Implementing a financial model that accepts Medicaid fundamentally changes the demographic of who gets to heal.
How so?
Well, it shifts evidence-based, highly specialized care from being a luxury good available only to a privileged few to an accessible reality for the broader population. A $10 to $40 copay represents a highly sustainable tier of healthcare pricing for ongoing treatment.
So what does this all mean? When you zoom out and look at the whole picture, this specific logistical setup fundamentally democratizes mental health care.
It does.
Your ability to get matched with a culturally competent therapist who knows exactly how to rewire your trauma using EMDR is no longer limited by your zip code, and is no longer restricted to this exclusive club of people who can afford to drop thousands of dollars a month out of pocket.
There is a really powerful synergy at play here. On one side, you have the clinical excellence, the intake architecture, the specialized matching, the specific neurobiological and psychological modalities, and the psychological safety of that permission to switch policy.
Right.
And then on the other side, you have the structural access, statewide geographical coverage through telehealth, the disruption of financial barriers through Medicaid, and accessible commercial copays.
It's a complete package.
Exactly. Combining those two sides creates a holistic healthcare model that actually meets the client where they are.
It really is a blueprint for how the mechanics of this industry should operate to serve the patient first. We've covered a lot of ground today, moving from that initial paralyzing dread of scrolling blindly through a massive directory to understanding the actual mechanics of how a practice translates a client's needs into a precise clinical match.
We moved from a model of blind chance to a model of intentional design. We explored the deep psychological importance of the therapeutic alliance and how securing that alliance is what actually allows the clinical interventions to take root.
And we saw how that entire structure is backed by the safety net of knowing you have total permission to change your mind if the human chemistry just isn't there, all without facing crippling financial or geographic hurdles. For anyone listening who is in Georgia and wants to experience this architecture firsthand, the source material provided the specific contact details for coping and healing counseling. You can explore their matching process by visiting brinchtherapy.com. You can email them directly at support@cheatstherapy.com, or you can literally just call them at 404-832-0102.
It serves as a remarkable example of intentional design applied to human connection and clinical healing.
It really does. And, it leaves me with one final thought to mull over. If the clinical data is correct, if this therapeutic relationship is statistically one of the absolute strongest predictors of success in therapy, how might the rest of our everyday lives change if we applied this exact same mindset?
Oh, that is an expansive way to look at the research.
Right. Think about our friendships, our working relationships, our creative collaborations. In life, we usually just rely on geographical proximity and pure chance to find people we surround ourselves with.
You just take what's in front of us.
Yeah, we throw a dart at the phone book and settle for whoever's sitting at the desk next to us or whoever happens to live in our neighborhood. But what if we applied this exact same intentional intake and matching mindset to our everyday lives? What if we stopped guessing, stopped settling for the first available slot, and started actively designing the alignment in our own lives, seeking out the specific modalities of friendship or collaboration that we actually need to thrive?
That is a truly fascinating concept to take with us into the real world.
Until next time, keep exploring, keep questioning, and stop throwing darts in the dark.